Okay, hi everyone. This is Sarah, and today I am going to talk about managed long-term care and how to get home care services through Medicaid managed care, and then also how to identify a case that might be able to be transferred to ICANN. We'll talk a little bit about who ICANN is and how they help handle cases. So on the agenda for today, we're going to talk about what managed long-term care is, how to identify an ICANN case. We're going to briefly go over how to join managed long-term care, because sometimes we're going to be able, or we should be providing information to clients about managed long-term care before transferring a case to ICANN. We're going to talk about how to get help from ICANN, and then go over a couple of administrative reminders and updates. So first off, what is managed long-term care? So long-term care is home care services where the client needs assistance with their activities of daily living. So primarily the big ones that we talk about are ambulating, transferring, and toileting. So they need to have some kind of need that's more intensive than just, housekeeping or laundry or preparing foods. It needs to be something where they really need assistance either walking or getting in and out of a chair or out of bed, toileting, or maybe, with personal hygiene, something like that. These are all services that are covered under long-term care plans, so that includes home care, adult daycare, private duty nursing, transportation to medical appointments, home-delivered meals, some medical equipment and supplies, hearing aids and audiology, and nursing home care. The important providers to consider when it comes to managed long-term care are physical, occupational, and speech therapists, and then vision providers, dental care, and podiatry. So I just wanted to point these out as these are the only doctors that are covered by the managed long-term care plan instead of the Medicare or straight fee-for-service Medicaid when someone is enrolled in managed long-term care. Just keep those providers in mind. We'll talk about them a little bit more in a minute. So there are different types of managed long-term care plans. So one type, if someone has just Medicaid but does not have Medicare, they still can get long-term care and home care services through their Medicaid managed care plan. So this is most likely the plan that they enroll in through the marketplace, and this is the plan they'd be able to get home care services through that plan. If someone has Medicare and Medicaid, they wouldn't be able to have that Medicaid managed care plan, and instead would get home care services through either the partially capitated managed long-term care plan or a fully capitated dual plan. So these plans are the fully integrated Dual Advantage program of all-inclusive care for the elderly, and the Medicaid Advantage Plus plan. We'll go over them briefly, but you don't really need to know too much about them. Really, the point of this is just if someone calls and says they're in an MLTC plan, they're in a FIDA plan or a MAP or a PACE plan, we should kind of throw up a flag or an alarm that maybe this is an ICANN case, and we should ask a couple more questions about their home care. So Medicaid MLTC is a separate health insurance plan that adds on to existing Medicare and Medicaid coverage. So a caller might still have their original Medicare or a Medicare Advantage plan, so they'd be able to go to the doctors, hospitals, and get their services that are in network for those providers. And then the Medicaid MLTC plan only covers the long-term care and those other couple of services we talked about. So this is where that vision, hearing, the podiatry, dental, and physical and occupational and speech therapy, those are the providers that would be covered under the MLTC plans. Everything else is just covered by their Medicare plan, either original Medicare or Medicare Advantage, and fee-for-service Medicaid would be secondary. So when people call, here's an example of the types of cards they might have where they would be in an MLTC plan. So I'm pointing this out because this could be a way to identify if someone is in an MLTC plan. Maybe they have original Medicare, they'll have their Medicare Part D drug plan, maybe they have a Medigap plan, and then they'll have their original Medicaid or fee-for-service Medicaid benefit card. And then they might mention that, oh, I have a Medicaid plan, I have a Medicaid managed care plan with, senior whole health or with Health First or United Healthcare or someone else, and they're convinced that they have Medicare and a managed Medicaid plan. So this is important because if someone's in Medicare, as we said before, you can't have a managed Medicaid plan while you have Medicare. So if someone's convinced they do, we might want to follow up and see, oh, are you getting home care services? Because this might be the way they're in a managed a Medicaid managed long-term care plan, which is just covering the home care. Here's another example of someone who might have a managed long-term care plan. They'll have their their Medicare Advantage plan, so they'll have their card that they use for their doctors and for their prescriptions. They'll have the Medicaid benefit card, which is the extra card that's tacked on, that covers the 20% or whatever services the Medicare Advantage plan isn't covering. And then again, they'll have a Medicaid managed care plan. So if they say, you know, I have Health First and I have United, or they mention two different managed care plans that are covering different services, a follow-up question would just be, oh, are you getting home care services, or do you have a home health aide? So in the combined plans, these are the FIDA, the PACE, and the MAP plans. We don't have to talk too much about what these plans cover and how they're different, because if someone says they have one of these plans, most likely it could be an ICANN case. But just to keep an ear out for these names, and that, you know, if someone says they're in this plan, again, that flag should go up. So in these plans, the caller would no longer have a Medicare card to get their medical care, and everything would be through this one combined managed care plan. So these plans, I should explain, they combine Medicare, Medicaid, and the long-term care services all into one plan. So if someone has this type of plan, they'll say, I just have my Health First card, I take it to all my doctors, it covers my prescriptions, they help me with my home care services. So if they just have one card that covers everything and they do have home care, it's probably one of these types of plans. Okay. So now we'll talk about when to transfer a case to ICANN. So ICANN is able to help people with, more specifically, you know, with questions about their home care. They have liaisons at the different plans, and they're able to follow up a little bit more closely with clients to make sure that they're getting the home care they need. So if someone has a home care issue or has a managed long-term care plan, ICANN will probably be the best suited to help them with it. Sometimes there's people who are in managed long-term care plans where it makes sense for us to help them instead, and so that's kind of on a case-by-case basis, but we'll talk through when to transfer a case to ICANN. So sometimes someone will call and they haven't specifically said that their issue is home care, but sometimes, you know, if you hear mention of a home health aide or a home care aide, maybe a case manager or a care manager, or if they have a Medicaid managed care plan in addition to Medicare, like I mentioned before, in these situations, we just want to follow up and see if they were getting any kind of home care services, maybe if they're in a nursing home, try and find out, you know, exactly what kind of insurance they have, and try and tease out if they do have a managed long-term care plan. So the biggest example I can think of as to why ICANN might be better able to help is if someone calls and they're losing their Medicaid, or they failed to recertify, or they got a notice saying they're failed to recertify, and their Medicaid case is closed, we would want to keep an ear out to see if they're getting home care services, because we would want to make sure all the appropriate steps were taken to make sure they kept getting home care services while they tried to get their Medicaid case straightened out. So in these situations, it might be the kind of case that we would want to transfer to ICANN so that they could work more closely with the MLTC, or they might be able to help the client with their recertification or trying to make sure that they keep their Medicaid case open throughout. So if someone calls and their question is specifically about home care, we have to decide if we give it to ICANN or not. So the first thing that we ask when someone calls and says, well, I need home care, or I have a problem with my home care, or something like that, we would want to find out if the caller has Medicaid. So if the answer is no, we can't transfer the case to ICANN. In order to be enrolled in MLTC or receive ICANN services, the client has to have Medicaid. So we would want to kind of help them through that process, and we'll talk about that more in a minute. If the answer is yes, they do have Medicaid, then it's possibly an ICANN case. So when the caller, you know, says they need home care, they want home care, and they do have Medicaid, first we want to see, you know, how long have we been talking to this client? If they call and this is within the first 2 or 3 minutes that we're talking to them, we haven't really gotten too much information, it might be just a good idea to say, okay, you know what, there's a better organization here who will be able to help you with home care. I can give them their helpline number. And then that way we could just kind of, especially if they haven't been going around too much. We don't like transferring kind of cold or just giving numbers out just to say go ahead and try this other number. So especially if we've done some intake or if we have some information, we might go over to ICANN, see if there's someone available to take the call right away. We could just transfer them directly. If it's a case we've been working on for quite a while and we have extensive notes, and then all of a sudden 3 days in they say, oh, my home health aide didn't come today, or they're saying they're going to stop my home care services, and it's like, oh no, here they have an MLTC plan, we might want to try and go over and just talk to maybe Anne or someone else at ICANN specifically about the case and try and transfer it over that way. Okay, so for times when people call and they don't have Medicaid but they want home care, we should be able to give them a little information first. We'll go over that now. Quick note, if someone is in a Medicaid managed care plan, like I said before, they can get home care services. So they would only have to contact their Medicaid managed care plan to request long-term care services. Someone in this category, we probably could refer to ICANN right off the bat and have them help them with the application or the request for home care through the Medicaid managed care plan. I just want to make a note that it's not crucial that someone have Medicare in order to get home care, just Medicaid. So when someone calls, they don't have Medicare and they need to get home care, as long as we can get them Medicaid, they can get home care. So here are the steps to enroll in managed long-term care. So I want to say this is one way to enroll in managed long-term care, and this can be kind of a lengthy process. So in a minute, we'll also talk about another way to get Medicaid and home care services. We're only really going to talk in detail about the first 2 steps, because after that, if someone calls and they're at that point, they should be able to go over to ICANN and get additional assistance. They'll be better able to help them. So the first step, apply for Medicaid. After that, get a conflict-free evaluation, and then they're going to have to get an additional assessment from the plan, and then choose which plan that they want to enroll in, and then enroll in that plan. So applying for Medicaid, it's just like a normal Medicaid application, non-MAGI Medicaid application through the local Department of Social Services, or if they're here in New York City, they would apply through HRA. There are facilitated enrollers throughout the state who can help. So if a caller is outside of New York City, we can refer them to their local FEABD organization, which is in the volunteer binders. And if they're in New York City, we can refer them either to Single Stop, Public Health Solutions, or if they're able to come into our offices, we should be able to set them up with an appointment here. It's the same criteria for other non-MAGI applications, so they have to be certified blind or disabled, and income and resource, or over 65, and income resources must be under the following limits to qualify. It's the normal limits is $862 for income. That's including the $20 disregard for unearned income, $1253 for couples, and then resources for a single person is $15,150, and for couples it's $22,200. There are sometimes deductions from income and resources, so it's always good to consult with the helpline staff to find out if the caller may be eligible in a different way. So we're going to talk a little bit about the spend down. So if someone is over the income limit and they need home care, we're going to be much more likely to help them get Medicaid than we might if someone didn't need home care. So sometimes we'll get someone calling saying, I have Medicare, my co-pays are too high, I want to see if I can get Medicaid. And then maybe they have a $300 or a $400 spend down, and so we'll try and direct them in a different direction, maybe help them with an MSP, an extra help, maybe try and see if a Medicare Advantage plan would work for them, but we might not encourage them to go for the Medicaid program because the spend down is kind of a tricky process to go through. So generally, if you just have Medicare and Medicaid and you're not getting home care services, that spend down has to go to Medicaid at the beginning of the month to activate the Medicaid case. If you are getting home care services, it works differently. Your Medicaid case is automatically activated, and you would pay your spend down to the MLTC plan each month in order to keep your coverage. So this is helpful because it gives the clients a little bit more flexibility. Their Medicaid case is active so they can go to doctors without worrying about submitting those bills, and they'll be able to kind of keep using their Medicaid as if they didn't have a spend down. And so we'll talk a little bit more about spend down. So we'll jump to the bottom. So one of the things you can do in an MLTC plan is you can kind of bargain with the plan and say, you know, my spend down may be $300, but really I can only afford $150. And sometimes the plans will say, great, just pay us that and we won't worry about it. Clients can be disenrolled from MLTC plans for failure to pay spend down. Don't worry too much about this, but just so you know, it just takes a little bit longer of time. You know, it's not something like automatically they'll be disenrolled. They'll be able to have appeal rights, and even if they are disenrolled, they'll be transferred to another plan with the same level of care as they were receiving before. So this is just to note that if someone calls, they're over the Medicaid limit and they would have a spend down and they need home care, they really should, they really should be getting on Medicaid, because that's going to be the cheapest way and the most affordable way for them to get home care. These are some other budgeting options for people with excess income. There's the spousal impoverishment budgeting. I don't want to go into too much detail because it's kind of complicated, along with spousal refusal. Spousal impoverishment is just a type of budgeting that lets one spouse who is not in Medicaid or managed long-term care keep more income so that the other spouse can get home care services without leaving the spouse that doesn't need home care services impoverished. So it makes it so that instead of that $1,253 limit that usually the non-Magi application, the limit for non-Magi Medicaid is, it makes it so that it's something in like $3,022 that the other spouse can keep. Again, just keep it in mind if someone is calling, it's an option. Again, a flag should go up and maybe we'll be able to discuss it. You can always feel free to ask me or any of the other helpline staff. Spousal refusal is another option. So the refusing spouse just kind of says, don't look at my income, don't look at my resources. But the problem with spousal refusal is that the county can sue the refusing spouse for support in order to recover the Medicaid funds paid for services when the refusing spouse refused. So technically Medicaid can come after that refusing spouse to try and collect the income they think that they're owed. There's a special income standard for people returning home from a nursing home or an adult home to go back into the community, so that there's a special rent allowance from their income. Again, just be familiar that this exists. And then there's the supplemental needs trust, the pooled trusts that can be set up to help clients with their excess income. Okay, so now the client has Medicaid. This is the application goes in, it takes 30 to 45 days to come back, and then the client has been approved for Medicaid. So the next step is to get this conflict-free evaluation. So we can give clients this number, the 855-222-8350 number, and a nurse from the state comes out and just decides yes or no whether or not the client is eligible for home care services. So they won't say how many hours the client needs, but they'll say, yep, you do need home care, you can move on to the next step. Or no, you don't need home care, sorry. And so if they say, no, you don't need home care, you can appeal that. And that is something that I think at that point ICAM would be able to help with, because the client does have Medicaid. So this is more, we just let clients know this is the process. You go get Medicaid, and then you get the conflict-free evaluation. And then after that, the plan comes out. You choose a plan you might want to enroll in. They'll come out and do an assessment and tell you how many hours they would be able to give you. And then you would enroll with that plan. And if they have additional questions about plans or other more specific information, we could refer them to ICANN at that point. Okay, so this process takes such a long time. It takes many months, and it gets delayed, and the plans are confused, especially if the client has a spend down or a surplus. They just don't really know how to deal with that. So an option for people who need home care more immediately is an immediate need for home care application with an immediate need for Medicaid. So what the caller, in order to qualify for this type of application, the caller must meet the following conditions. So they must have an immediate need for home care, no informal caregiver available, no home care agency providing assistance, and no third-party insurance or Medicare benefits available. So basically, the best example I can think of is all of a sudden, mom or dad has an accident and ends up in the hospital, and they have a significant decline, very quickly. And then all of a sudden they have to go home, and they're not really able to take care of themselves themselves, and they won't be for a while. But there's no informal support available, and so they need home care services much more quickly. And so I think this is a good time to kind of talk about the immediate need application and see if maybe we can get them home care much faster. So that process before, like I said, can take 5, 6, somewhere between upwards of 3 months in order to get home care services start. This is the timeline for an immediate need application. So when you submit immediate need for Medicaid and home care, the application must be processed within 7 days. So after 7 days, the Medicaid office has to come back and say, yep, you can get Medicaid, or no, you can't get Medicaid. After that, if you're approved for Medicaid, HRA must conduct a social assessment and authorize personal care services within another 5 days. So instead of at least 3 months, we now have home care services within about 12 days, which is really just so much faster and so much better for the clients. So after that, home care services will begin through CASA, which is kind of like the home care agency through fee-for-service Medicaid, and then the client will transition into managed long-term care within 3 months. They can choose their plan, or they'll just get automatically enrolled into a plan after 3 months. This is the documents that the client needs in order to apply. So it's the normal Medicaid application with Access NY insurance application, Supplement A, and then the additional pages that the client will need is an attestation of immediate need, and then an M11Q signed by a physician. So this is a medical request for home care, and it has to be the 2014 version instead of 2009. HRA only will accept 2014. They won't take the 2009 version, so it's really important it's that one. And it has to be signed and dated within 30 days of the submission. So it has to be a recent request that they can submit. And then if we're submitting from our offices, we'd want to submit a HIPAA authorization that says we can follow up on their case. And then we could also ask them to write a cover letter explaining why they need immediate need. Okay, so that's how you get Medicaid and how you get home care and the options we can explain to clients. And as always, if you have any questions, definitely feel free to ask me or anyone on the helpline staff. Okay, so who is ICANN? ICANN is the Independent Consumer Advocacy Network. They're New York State's ombuds program for people with Medicaid long-term care services and help New Yorkers to understand how to enroll in and use managed care plans that cover long-term care services, specifically home attendant services or nursing home care. So they help anyone enrolled in a Medicaid managed care plan who needs long-term care services. So if they need a home attendant or adult daycare or a nursing home, they'd be able to help them. They can also help people who are newly eligible for enrollment in a Medicaid managed care plan and talk to them about choosing a plan and then going to enroll. They're able to talk to families, family members, friends, social workers, providers, and anyone else who is helping people with their healthcare decisions, especially because a lot of their clients might not be able to advocate for themselves. So what do? They'll answer questions, give advice, help people enroll, help identify and solve problems with MLTC plans, let clients know their rights, help file complaints or grievances if the callers are upset with the plan action, and then help appeal actions that the callers disagree with. Again, no need to memorize these, but these are just the acronyms to look out for. If someone calls, says, I'm in a FIDA plan, we immediately think ICANN. If they say they're in a HART plan, we'll go discuss it with ICANN. MLTC, same thing. Here's their helpline number, and in case you're interested, their email address, and then their website. So, like I said, if someone calls and is, 2 seconds into the conversation, say they're calling for home care, give them the helpline number, or we could go over, try and find someone to transfer them directly. Otherwise, if we've taken more detailed information, we'll just go ahead and find Anne or someone over at ICANN and see if they can call them back. That's ICANN. Okay. Now we're going to go over a couple of administrative reminders and general updates. So the biggest update is that as of May 1st, Medicaid managed care enrollees who wish to appeal service authorization denials or terminations will have to request an internal appeal before requesting a fair hearing. It used to be that if you got an adverse determination from Medicaid, you could go straight to a fair hearing, and you actually had to request a fair hearing within 60 days. But they've changed that now you have to request an internal appeal before going to a fair hearing. So one thing to note is that if you are getting a reduction or a termination of services, or if an enrollee is getting a reduction or termination of services, they are able to get aid to continue or aid continuing during the appeal process. So the same way that you'd be able to get it during a fair hearing, you now will be able to get the aid to continue during the internal appeal. In order to get aid to continue, the enrollee must request the internal appeal within 10 days of the date on the notice or before the effective date, so whichever is later. Once they've requested the internal appeal, and if it meets this timeline, they'll automatically get aid continuing. Once the decision comes back from the internal appeal, if it's adverse, if it doesn't give the enrollee the decision they want, it's the same rules to request the fair hearing. So they'll have either 10 days within the date of the notice, from the date of the notice, or before the effective date in order to request the fair hearing with aid to continue. Just a note, if you lose, or if the enrollee loses their appeal or fair hearing, they may be held responsible for the cost during that time. I have no idea how often Medicaid actually goes over after these costs, but it's just something to be aware of, that it is something they're legally able to do. Okay, so you must file for an internal appeal within 60 days of an adverse determination. Requests can be initiated orally, but if the enrollee is requesting a standard appeal, they should always follow up in writing. It's always just good advice to follow up in writing so that there's a paper trail. If someone else is requesting the appeal on behalf of the enrollee, they must submit written consent. So these forms will be sent out with all adverse benefit determinations. That won't be something that we see too much on the helpline, because we probably wouldn't be helping with an internal appeal. Just something to keep in mind if someone calls to ask. Once they've requested their internal appeal, enrollees should automatically receive their case file. It should come in the mail. Again, we'll see how often this actually gets sent out. Plans are supposed to automatically send out their evidence packet for fair hearings, but they wouldn't always do that. But it is something that if we ever call the plan, we should make sure they're sending out the case file and make sure that they're aware that they're supposed to be doing that automatically. The decision deadline for an internal appeal is still 30 calendar days for a standard request, but is now 72 hours for an expedited request. So that's up from 3 business days. Now it is 72 hours for the plan to respond to a expedited request for an internal appeal. Another change is that enrollees now have 120 days from the date on the final adverse determination to ask for a fair hearing. It used to be that you only had 60 days from the initial adverse determination. Now enrollees will have 120 days from the FAD to ask for a fair hearing. So these are the steps to take if a service request is denied. I'm not going to go through them, but I think they're nice graphics that go through, if you ask for a service, it's denied, and then you ask for an appeal, you get a denial, and then the process after that. And then here's a nice graphic for how to make sure that you get aid to continue throughout the process if the enrollee is getting a termination or a reduction in their services. Okay. I also want to go over the Notice of Privacy and Practices. So we have a Notice of Privacy and Practices that's available for all callers, and this is available on the portal. This document notifies consumers of their privacy rights with regard to their personal health information, lets them know how we may use and disclose their personal health information, instructs consumers how to file a complaint if they feel we've violated their rights, informs consumers of our responsibilities to protect their health information, and instructs consumers on how to request their records or request a restriction on the use of their records. So this is a very, very important document that is available on the portal. And we want to make sure, that we're letting callers know that this is available. So when they call the helpline, we want to briefly explain our privacy and practices and direct callers to our website if they want additional information. If they request a copy of our Notice of Privacy and Practices, we must send them a copy, and we can send them an electronic copy, but we must also send a paper copy if the caller requests it. I'm going to send out the PowerPoint, and here's the link to the Notice of Privacy and Practices on our website. And I just want to make a quick note that our helpline message has changed so that it includes, makes callers aware of their Notice of Privacy and Practices and that they're available to them if they want them. So here's a model script. You pick up the phone, you say, hi, this is Adri, or hi, this is Sarah with CHA, how can I help you? Client's going to say what's going on. They'll try and, get out as much information as they can. You say, okay, I want to open a case for you and provide you with more assistance. But before I do, I want you to know that all the information you provide is confidential. Are you interested in learning more about our privacy practices? If they say no, you can go ahead and move on. If they say yes, you can say CHA adheres to federal and state privacy laws to keep our clients' personal information, personally identifiable health information secure. For consumers who have any questions about their privacy rights and how to use their information or how their information is used, we have a document on our website called our Notice of Privacy Practices. We can tell you where it's available, or I can email you or mail you a copy if you like to look at it. The client requests a copy. Again, we must mail one, even if we also send them to our website. If the client has further questions, you can refer them to the helpline supervisor. Sometimes I'll incorporate this as, I have some nosy intake questions to get you in our database, just to let you know all of our information is completely private. We abide by HIPAA laws, and we do have a Notice of Privacy Practices available online, which I can direct you to. And if you're interested, I am happy to send out the paper as well. So it's a way to kind of incorporate it into, requesting the additional information to get them in our database. Okay, another note. We're still seeing a number of cases that don't have phone numbers, and phone numbers are arguably the most important number we can get, even if we don't get someone's name, as long as we can call them back. That's super important. Obviously, always get someone's name, that's saying don't get other information, but this is the most important one. Please, please, please always double check that you've saved it in that slot. Sometimes, if you go and you search for a client and they don't come up and you say add new case, I know for a while I thought maybe that information would get inputted, but it doesn't. So you want to make sure that you're entering it in again. A note about external appeals. So this is just to remind you who has external appeal rights. For fully insured plans, it's people who are being denied based on medical necessity. If it's, the procedure is experimental or investigational, or if it's an out-of-network service. Self-insured plans is for decisions involving medical judgment. We will have a new documents checklist that I'm going to include hopefully in this PowerPoint, and will be on the advocate-facing side of the portal. And we can go over that next time, or feel free to ask any questions. Hopefully when that portal is updated, we'll be able to find it a little bit easier. So again, just to kind of make sure that if you're sending out that checklist, it's only for people who are at the external appeal point. We want to clarify the document that they're getting, if it's an EOB, if it's an explanation of benefits, an initial adverse determination, or a final adverse determination. So we don't want to be sending out this documents checklist unless someone is getting a final adverse determination and they have the right to an external appeal, because it's kind of a long list and we don't want people going through all this work if we can't actually help them and they don't have any external appeal rights. So I'm working on a form that's going to kind of help, let you know when you should be calling the plan and what information we need, and make sure we're checking all our boxes before we have clients going to find all this information. Okay. Other last administrative reminders. At the end of the day, don't turn off the computers. Just log off. The computers, I know IT does some work with them at night, so we definitely don't want to shut down the computers. Just, log out and then we're good. Make sure you're signing off the helpline when you go out for lunch, if you take a bathroom break, if you're coming to ask questions, and then definitely at the end of the day when your shift is done. A quick note, the helpline supervisor in the database is always going to be HL Supervisor Sarah L., regardless of who is supervising. So even if Michelle is supervising, or Diane, or Priscilla, if someone else is there, the case should still go in under helpline supervisor Sarah L. for primary caseworker. Also, a quick note, HITCAP calls are also under HL Supervisor Sarah L. now, so don't put that under the HITCAP supervisor anymore. Super, super, super important. Make sure you're always opening cases and recording the cases on the tally sheet. Any call that comes in should really be entered into the database and made note of, just to say, you know, we had this person call, this is the information that was provided. It's just incredibly important to make sure that we're recording all of the cases that come through and all of the calls that come through, and that we have written record of the information that CHA is providing. And the way to do that is to open a case in the database. So if you have any questions, I mean, when in doubt, open a case, and we can always, well, there's no case that we would end up closing. So yeah, always open a case, and when in doubt, open a case. Feel free to come and ask me or any of the other helpline staff about cases if you're unsure or confused, and we're happy to talk about it. And then make sure you're recording all of the cases that you've dealt with throughout the day on the tally sheet. So these are the cases you've opened and calls that have come in the helpline that are existing clients that you're then helping, helping further their case, or if you're doing callbacks, callbacks and you've opened a case, or if you're doing follow-ups, just make a note of all the cases that you've worked on and recorded on the tally sheet. Okay, so for now, I think the person you should be referring scheduling calls to is SADA S. And the super important thing that I keep forgetting is to make sure that we know what county the caller is in before we transfer to her. She only schedules calls for New York City, for the navigators here at CSS. So as long as they're in New York City and they're willing to come to our offices, or maybe Harlem Hospital or Jacobi, we'd be able to refer them to SADA. But if not, then we would want to refer them to their upstate agency, either the CNN agency or, depending on what kind of help they need, maybe their FEABD agency. We also want to make sure that the people we're referring to SADA are able to get enrolled in health insurance. If someone calls, right now you can enroll in Medicaid and Essential Plan at any time, but because it's not open enrollment, if someone's calling saying they just need health insurance, they're over income limit for Medicaid or for Essential Plan, and they don't have a special enrollment period, they wouldn't be able to enroll. So we'd want to ask a little bit more about if there's been any change in employment, or if there's been any other qualifying event that might let them enroll in health insurance outside of open enrollment, but we'd want to know that before transferring to SADA. Okay. Another quick note, just try to make sure that you're getting the numbers. If someone's calling saying, I'm getting this bill, or the health insurance is denying this service or not covering the service, try and ask how much the bill is for, or what the cost of the service is, just so we can kind of keep track of that in our case savings. Another thing is just, callers with Medicare, if you remember, just remind them to update their address with Social Security, because the new Medicare cards are going out. So it could just be a nice friendly reminder of, hey, you're getting a new Medicare card. Make sure they have your right address, so that if they call, when they send out the card, it'll be to the right address. Then this last note is I've just been working on a couple of guides to help with questions about enrollment and appeals and billing, and I'll be sending those out sometime soon, hopefully. And so, we'll be able to talk about those, and hopefully that'll answer some of these questions that we have. Okay, that's everything for managed long-term care. If you have any questions, please come find me, and we'll talk about it. Thank you.